a pleasure for me to be here with you. I want to share my experience. Principal is the first objective. I work in a team group. It's not the result that I will show you is not my work. It's the work of many people. It's a team. And it's the best way to obtain the best results. I think that. Thank you, Tito, for introduce me. And I'm Tomas Castellanos. I study dentistry at the Javeriana University in Bogotá, Colombia. The postgraduate study in the orthodontics and maxillofacial orthopedics in Universidad Militar Nueva Granada. I am here with Tito. During this week, we enjoy really San Antonio. I just been here in last year, just for a couple days here with your group. But now we had more time to share and to know more about the culture of and places of San Antonio. Yes, I'm here with my wife. I'm very happy to be here with our baby because she is pregnant. She has 5 months. It's Tomas Andres. During my career, I have the opportunity to have very good doctors, very good professors. They teach me many things about ortho and about the concept of the beauty. One of these is Dr. Cesar Guerrero. The evolution of the cases is fantastic. He actually is close in here, is in Galveston, and he treats the cases in a fantastic way. Dr. William Bell, he was his professor and our professor. He was in 2004 in Caracas, Venezuela. And this is one of the groups that I am working with this group. I am teacher in this group. Is the master of Dr. Tom Pitts. And I am in some association. This association is international for orthodontics and maxillofacial aesthetics, because the only thing is not just the teeth. You need to pay attention in the face. The first step is the face, and next you can zoom in and go to the teeth. You can improve everything. We have some congress around the world and some meetings, and it's a very, very progressive group. We have some researches, and with the researches we work in genetics, in biomaterials, in bruxism, surgery first, aesthetics. Smile art is part of this aesthetic. This is the world. Here is Colombia, in the center of the world. For me, for me, I don't know. If you want to go there, welcome there to Colombia. It's very close, just 5 hours and 30 minutes from Bogota to Houston, and Houston here is very, very easy. Okay. Colombia, we have very nice beaches. This is San Andres. This is the Colombian coffee. Flowers from Colombia. James is I don't know about soccer. Yes. Shakira came from Colombia too. And I have the pleasure to work with the Miss Colombia pageant. We have patients, and they come from many countries, and we treat patients for beauty queens too, for another kind of contest from other countries. And it's a social mission with this contest. Yes, we work for children and for another kind of charity. I've been in different congress, like Tito says. This is the biggest, largest, tallest building in the world. And this is from Fernando Botero from Colombia. It's in front of this. It's a very good sculptor. Okay, Tito, thank you to invite me here. We have a very nice trip in this limo last weekend. We went to the Cape and a special concert for the Valentine's Day. Yes. Okay, this is aesthetic in ortho. It's an interdisciplinary vision about our profession. It's not multidisciplinary, because when you talk about multidisciplinary, each people, each specialty work one there, the other one there, not together. When you put everything together, you have the goals. You can obtain the goals. Okay, this is a Colombia TV commercial in TV. It was in TV some years ago. Is the same patient than in the commercial? The same person, maybe? You think that? No? But he is, no? It's the same person. Just before and after treatment. With an interdisciplinary treatment. This is before. He is Carlos Eduardo. And he has a problem. He had a problem in the face. The lower face was longer, and he had a smile arc, reverse smile arc, and open bite. He couldn't speak good too for this problem, and the bite wasn't good too. We treat this patient in 2007. It's a learning curve, but we can change the life of the people if we put everything together to do that. This is before and after treatment. It's before and after. It's a combination of maxillofacial surgery, periodontist, orthodontist, and aesthetic. Yes, it's a combination of everything. And we can obtain this result. This is, the patients are looking for this, yes? For the best aesthetic and for the best occlusion and best function. We need to look that. And we can improve the breathing too. We can improve the breathing in the patients. We are not looking for this. Just align the teeth. Yes, this is amazing. We are not looking for that. But sometimes people think the ortho is just to obtain that. Or maybe we can close the spaces, no? Of course. It's brilliant. Amazing, no? No, we are looking for more things. We are looking for this, for beauty. The patient looks for belleza, for beauty, to look younger, for faster treatments. This is very important, the aesthetic and the anti-aging ortho. We are the buildings. Yes, we are the constructors of the engineers for these smiles, yes. And I came from a family, and they are artists. It's my mom and my aunt. She passed away 1 year ago, my aunt, and she was an artist, and I came from artists. This is a study. It's in Medellin, Colombia. It's about another family of mine, and he's Justo, and I started to painting when I was a little boy. Yes, this is the study, and it's amazing. He created very nice pictures. To say sculptures. Yes, this is the studio. And my cousin, my aunt, yes. And when you analyze the aesthetic, when you need a subjective vision, not just take measurements or not just the cephalometric study can show you the real problem of the patient. You need to You need to see the patient first in a static and dynamic evaluation, yes? And you know the proportion is the most important thing when you are thinking in aesthetic. You know, you can see that the studies is the Fibonacci, for example, the numbers for the perfect beauty. But the most important thing is you can apply this concept in the old construction and in the new construction. And in the faces, of course. Through the time, you can analyze different heritage, different cultures, different kind of people, and different times. And you can see similar things in the smiles. It's very important, the face and the smile. Different people, different kinds of people, different profiles. But it's in common one thing. Proportion is very important in the aesthetic. The lips, the teeth, the smile arc in this case. It's very important, the symmetry, everything is important. Emeralds from Colombia. It's the only country when you can find the emeralds. You can see the aesthetic. You can see the aesthetic. You don't need to study a lot, but you can see the aesthetic in the people. You know where is the perfection, where is not the perfection. We are looking to improve our patients, yes? And people, how people knows about aesthetic? They have a magazine. They can read and they can see pictures about celebrities, and this is very important because with these instruments and the internet, of course, they go to our clinics and then consult because they want to improve the aesthetic and the function, yes? And sometimes they know more than us, yes? They know about the methods and about the best way to obtain that and the faster treatments. We need to know what the patient wants, yes? Sometimes they go to the wrong doctor or to the wrong consultant. And sometimes the results are not the best, yes? It's not the best results. We are not looking for this, yes? But sometimes they are looking for aesthetics. They find a doctor or another profession maybe, and they prescribe the wrong treatment. This is a smile design, supposedly. No, Dr. Lisa, this is not good, no? Because this is very quick. People are looking for a quick treatment. Maybe it's not the best, the quick one. Maybe it's good time, faster, of course, but you need to follow the steps and to put the specialties together to obtain the results. Yes? I don't justify a lot of endodontics for this treatment, and the final result is not the best one. You need to analyze the patient in 4D, the 3 dimensions and the time, because we are treating patients not for now, not just for now. You need to see the patient, keep in mind the patients in the future, maybe in 10 years, in 20 years, yes? How will be the patients? All patients want to maximize aesthetics and look more youthful. This is in Miss Colombia pageant. We can do that. Here's Paola. Here is Paola. She was the Miss Universe, the last Miss Universe, Paulina. And there is Paulina and Paola here. She's another patient, Diana. And they are in magazines sometimes. And the people can decide how they can aging. Yes? Actually, we have the option to aging in this way. same generation, and it's different. We are changes. We are not static. We are not models, no articulators. We are changing. But we can decide how we can do that. Journal in 2000, and it says the expectation of life here in United States is not America, because America is from north and the south. Chile is American, Puerto Rico is American. Correct. Yes. It's United States, yes. And they say the expectation of life in 2000, it was 100 years, yes. But this is for a couple years ago, and it says the expectation of life is 120. Just in 15 years, changed the expectation. And we have more work now. It's not easy, yes, because the patients are expected to be jawed and to have a very good smile for more than 1 century. And we need the capacity to obtain that. Maybe we need to put braces not just 1 time. Maybe he needs more times. And periodontist, of course, and the aesthetic, of course. We need to go with the patient and to fix the problem in the patient. In many times, it's a very big compromise. 200 years ago, during the times of George Washington, I think that is the expectancy of life. It was 28 years old in the United States. What do you think? It was amazing. Not everybody lives until 28, but it was the average, okay? Now it's 120. We have more work now. People with 99 years old looks perfect. We can do that now. It's an exercise. Voluntaries, please. Yes, 83 years old. Yes, it's amazing. 106. He's working in New York, in Wall Street. It's amazing. And what happened? With the time, the upper lip is down, okay? And each day, you show less upper incisors and more lower incisors. Visual effects, special. Look at. Each day, you show less than the upper and more than the lower. This is no good. And another thing, with the conventional orthodontist method, usually they have extraction of the premolars. Actually, we just extract the premolars by the profile. If the profile needs, you can extract. If the profile don't need, it's better than extract. Why? Because with the time, the progress of the aging is the lips will be more back. Yes? And it is not good. If you extract, you can obtain this result early. We can obtain the similar result with ortho, but without extractions. Look at this. And it's in 12 months of treatment. We can obtain a good result. We can improve the development of the arches. And it's good. Is the patients are looking for this. Patients are looking for this to look better. Perception is very important in aesthetics. Yes? It's not the same, this patient. This is just a diagram. Yes? It's not the same, this patient. When you see this patient, when you talk with that patient, maybe it's not good. And the self-esteem, maybe it's not good too. It's better here, no? People feel better. One of the manners to study the perception, the subjective evaluation, is the macro, mini, and microaesthetic. Dr. David Serber, he was my professor too here, is a specialist in this analysis. And we can see the patient here. Look at the profile, front view, and look at the intraoral pictures. Crowding is here, class 2 from one side, some things, but the worst thing here maybe is the macroaesthetic and the microaesthetic. I will show you why. Profile. We can put a punctuations here. High need is 1, moderate need is 2, average need is average need, and mild need is 4, and no need, it's fine, okay, is 5. I put in the profile the number 2 because the lips are very forward, yes, because she had a proclination and she needs more chin. She needs more projection of the chin, okay? Vertical dimension, 4. Lip fullness, 1. Nasal projection is no good. We can improve the nasal projection, and it's easy. I put 2. Chin projection, 1. Facial, height, and width, 4. 2, 1, 2, 1. Here, the macroaesthetic, the front view. We can see the incisor display. But we can pay attention more in the mini aesthetic. When I talk about the mini aesthetic, I talk about this area around the lips and the teeth, the smile, okay? How is the incisor display? It's good. Incisor display, yes, transverse smile dimension is fine, but we can improve that. Restive knee support, 2. Crowding is not bad, 3. Smile arc, 4. Buccal corridors and gingival display is not bad, the mini aesthetic. And the mini aesthetic and the microaesthetic now, we can find more things. Tooth shape is not fine. It's the worst thing here. If we put braces here, it's easy, but we can correct everything in the best way, okay? Because it's better when you have the perfect anatomy. You need to find the best anatomy possible before start with the treatment. Look at here. We can do interproximal reduction to improve that. IPR. Thank you to teach me that. Julie. Okay. The words, yes, are very important. And for the upper, because I say the stripping, and stripping maybe the meaning is different ways. IPR sounds better. Okay. And in the upper teeth, look, the position of the laterals and the shape. We need to fix that before put braces. It's not just put braces. We need to recover the anatomy. Tooth color is fine. Tooth contacts, 1. No good contacts here. Gingival height, gingival quality, doctor. It's fine, it's not bad. Gingival contour, zeniths, and gingival attachment is not bad at this point. But we need to improve. Look at here. If we can take measurements of this, we have this result. 7.5, 7.5, and 7 millimeters. This is very big lateral. We can recontour and we can build up this. This is the shape. This is not a good shape. When you take a pictures and the patient open the mouth, the camera is terrible. The perception in the pictures is not good. We can improve that. We can do that. It's easy. We can recontour that before start with the treatment. And we can improve the gum too. We can start with this anatomy. Now, it's important to pay attention not just in the edges. Sometimes we put braces in front, in the buccal face of the teeth, and this is not flat. This is no good. They have irregularities, and we need to pay attention in that. Look at here. If we fix that, we can put very good braces. And we need looking for the dimensional ornation of the maxillary mandibular anterior teeth. This is the Bolton analysis. If we do that, we are more sure that we will be able to obtain a class 1, cuspid class 1. This is very important. Look at here, the beginning, and 8 months later. We use a mini screw too. This is very easy to do that now. This mini screw, we put this in front of the teeth, parallel to the roots. And we can move everything in mass. We can obtain a mass retraction. This is very good concept. It's very good because you can fix the patient without distraction. You can fix a class 2, for example. Here, this is the summary of the treatment. Look at here the screw, 12 millimeter screw, and look at the power chain. We start with the power chain, actually, and with the desocclusion and with another mechanics from the beginning. We use low forces because the low forces are more biological, and the patients like more because they can avoid the pain. They don't like the pain, of course. Here is the summary. And this is the end of the treatment. It's in class 1. Look at the changes. Here is different. And look at here, the panel. Here is the chin. This is the osteotomy to advance the chin. And Dr. Mauricio Serrano did the rhinoplasty to improve the projection of the nasal projection. And Dr. Alejandra Rojas, she did the chin surgery. It really changed. Look at here the summary. At the beginning, the measurements. After, build up. And at the end of the treatment. Here is the final measurements, final result, and a smile arc. This concept is very important, the smile arc. Begin with the end in mind. Tom Pitt said that he's my professor, and I learned about him many things. We designed together a special chart to put the braces in the best position in the way to obtain a smile arc. But other thing to improve the smile arc sometimes, if the patient had a very hard muscles, the pressure muscles, at the sides of these muscles are at the sides of the mouth, yes? We can use Dysport too. Dysport is a botulinum toxin, like Botox. And we can put here in these muscles, and we can improve the smile arc. Look at the patient in 3/4 view. Now look at the patient here, smiling. Consonant smile arc. Look at between the upper teeth and the lower lip. This is consonant smile arc. Look at here the patient, before, after. Because sometimes when we have a deep bite, for example, we try to solve this kind of problem just intruding the uppers and lowers. Sometimes patients don't need that. because when you intrude the uppers, you can fix the deep bite, but you can empeorar.
Ruin the smile arc.
Ruin?
Ruin.
Ruin the smile arc. Okay. Patients are looking for improve. This is flat. It looks old. This is the arc, jaw. You can see a smile arc. It's the perception, the most important. Sometimes we are orthodontists, we are dentists and hygienists, yes, and we are looking for straight teeth and alignment teeth, and sometimes we pay more attention to that concept, to the smile arc. She is Paula Turbay. She came from Colombia too, and she's Angelina Jolie. You know who is I introduced Angelina Jolie to you. Okay, they have some in common. Smile arc, and look at the face, the relation between the face, the lip, and the jaw is more longer here. It's longer here. This is more square. It's different. This kind of result is a smile arc, but this is a smile arc too, but different. You need to pay attention in this when you are looking for a smile arc. You need to analyze the face first before put the braces. But here, you can see the smiles. As you can see, the lateral are not in the best position. Here, they are in the best position. Here, not. What say that? The camera, for the camera, is most important the smile arc than the position of the laterals. But we need to looking for both. Yes, the smile arc and the best position of the teeth. Okay. With the old concepts, we fixed it, the deep bite, but this is worse now. We are looking for the smile arc. The traditional mechanics, they can align the teeth, but they will obtain this result. It's a poor result because it's not consonant with the lip. It's not aesthetic. This is the flat and the consonant smile arc. It's different. It was my patient some years ago. I put the braces with the regular position, and I obtained this result. During this time, I was very happy with the result. But actually, I am happy with the result. Don't say that to the patient. You just see the patient. Yes. Now I am looking for this, for the smile arc. Smile, Paola. And open bite, for example, is another kind of treatment. Yes. You need to see the patient before it starts. And you can put the braces whenever you want. If you want to put more gingival and more incisal, depend of you. Depend of the diagnosis. Depend of the result that you are looking for. This patient has inadequate incisor display, anterior open bite. You can see the open bite there? Yes? Okay. Systematic approach to function and aesthetic is the best way. We can cut this too. And we can improve. Like Wolverine, yes. Wolverine? Okay. Okay, the open bite, sometimes you can consider this open bite like surgical open bite, but the position of the teeth is the real problem here. You have an interference in the third molar, and you have a position of the anterior in a reverse smile arc. How we can fix that? Put the braces in the best position. We can obtain a straight arc, but with a smile arc result. I know this is a short time, but I want to share with you that. I think these concepts are good, yes. Maybe you can put this in your next patient, and if you can do that, I will be very satisfied. If some of these concepts are good for you. This is the result. And it's important the recontouring, of course, the build-up. It's very important, the bracket position, because can make a big difference in aesthetics. Reading is better. Look at here the smile arc. Look at here the position of the braces. For many people, I was crazy when I did that. I showed that case the first time some years ago at the AAO. And some people, they thought I was crazy. But actually, more people are thinking the best way is not the easy way to put the braces in the middle of the crown. Is you think you need to customize the position of the braces to obtain the better result. I put that here, and I obtained this result. Very easy, just in 12 months, without surgery. Because it's easy, it's logical. If I put a wire here, the wire tendency is to be straight. When it will be straight, he will push down the incisors, and you can obtain this result. Different, aesthetic, dramatic changes. Look at the profile. I used two mini screws in this part with a rubber band from the upper incisors to the lower arch. And we obtain a consonant smile arc too. Before and after is Ernesto, is my patient. He never consulted me. He never find for ortho. His wife looking for the treatment. But he is very happy now with the result. Smile arc. We are here with Ernesto in Bogotá. Altering functional occlusal plane is another concept, it's similar. Here's Sabrina, John, Tom, some friends. And look at here, he's Edward, another patient. And he was 22 years old. He was wearing and flaring of upper incisors, previous ortho treatment, and heavy bruxers. Look at the teeth. He had previous ortho treatment 2 years before the treatment. They align the teeth. He doesn't have crowding. This is not the problem. It's not just for a line. But we can improve that. It's not surgical patient. But the changes that you will see in that patient will look like a surgical patient. Why? Because we changed the functional occlusal plane. How we did that? First option. You have many options to improve the profile, but sometimes are not the best. We have the option to the extractions. We can extract the 4 premolar, and we can push back the upper and lower incisors. It's the easy way. But if we are thinking in the time in 4D, this is not the best thing for the patient in the future, because the aging will become early. Yes. We have another option. We can extract the 3rd molars, and we can push back everything together back. The position of the upper incisor, flat functional occlusal plane, flare upper incisors, reverse smile arc, and decrease lower facial height. Look at the superimposition. the position of the lip is influenced by the position of the upper incisors. We are looking for this. We are looking for obtain a functional occlusal plane rotation in the clockwise, at the clockwise. Treatment plan. What is the first step? Put braces, maybe? Go to the periodontist, of course. Yes. Doctora Luisa, por favor. But the next step. Okay, the next step is not put the braces, maybe. Different. Where is the problem? The first problem here, the big problem here, are the masseter's muscles and the temporary muscles. If we don't solve that, we can find the result. Because if he had a very big muscles because he clenched at nights, yes, and with this exercise, he grow up the masseters, yes. We need to treat first this. And we had a very good experience and research about that. I worked with DISPOR from 10 years ago. I started with them. And when we detect this kind of patients, the first step is put injections in the masseters and sometimes in the temporaries. Yes? It's the same, similar medicament, but the doses are different than when you use the DISPOR for the wrinkles, because they are very little muscles, big muscles here. When we put this toxin here, the effect, we can obtain the effect maybe 1 month after put that, okay? We had the measurements with electromyography, and we detect resolution, not just the symptoms. We obtain a very good result because we decrease the force level in the muscles in 40%. This is very important. 40% less. This is the first step. The second step, the first step, periodontist. Second. Yes, and this is to illustrate the steps. Perio is here, and the second one is muscle balance, yes. Dental anatomy, the build up, and if you need, you can recontour into. Bracket position, this is the GPSA by Tom, and the anchorage for this case. And biological activation, we can do that. The commercial name of this is Propel. And this is very good because you can go fast through the treatment. You need to take advantage of the elements. We have very good elements actually to improve our treatments and to go faster at the treatments. First, period. Second, DISPOR, and build up the centers. Look at here, looks different. Here, initial, after build up. You can see the stains here. He had a previously ortho treatment. Look at the mistakes in the bonding. For that reason, they couldn't obtain the smiler and they couldn't obtain the rotation of the mandible. Yes? We start with these arches and we put, for the next appointment, when we put the braces, we start to, at the same time, with the screws. Smiler, obtain a smiler. This is the regular position of the braces, and you will obtain this kind of result because it's flat and flat here. We can obtain the result, put all tools together. The DISPOR, the position of the braces. Invisalign can work too for this, of course. But the disport is the concept too, and the rotation of the planes is very important. Here, look at the position of the braces. Looks crazy maybe, but it's the divergence, planes divergence. Is more occlused the second molar and is more gingival, the anterior teeth. Look at the rubber bands. We start with 2.5 ounces rubber bands. 4 from the screw to the cuspid, the upper cuspid. And we start with a 2.5 ounces power chain from the screw to the premolar to push back the lowers and to push back and to promote the rotation of the occlusal plane in clockwise. Here, here. We use a table to determine the more exactly quantity of force. We take a measurement from point A to point B. We go to this table, we select the force, the desired force, and we can obtain the elastic. It depends on the brand that you use, but this is very useful. It's more predictable, the level of force. And we put the screw in this zone. We use the turbos. Sometimes we put the turbos at the cuspids. In many cases, we put the turbos in the incisors, but sometimes we put the cuspids, especially in the cases when we had a very reverse smile arc. Yes? Because it permits the development of the smile arc. Okay, here's another appointment. It will change. This is 142590, third appointment. We use this kind of power chain too in the upper and lower to push back, to retroline the upper and lower incisors. And we put this ligature to improve the anchorage. Look at here. We use the screws here for the extrusion, to promote the extrusion of the upper incisors. These braces are H4 braces. Look at the smile arc now. And the end of the case. It's different. Initial, finish. Class 1 here, class 1 here too, but the occlusal plane is different. When we change the occlusal plane, the results, you can find results not intraoral, you can find results extraorally too. And this is most important. It's important to obtain mutual protected occlusion in central relation. This is the goal when you are looking for a stable ortho, more than the retainers. Look at the stability here is very good. Result here. We change this part of the face, but we change this part of the face too. Look at the upright incisors, meaning incisors display, more incisor display. We did that. It's easy. Look at before and after, and we change the occlusal plane. This is the difference. When you change the occlusal plane, the lips will be changed too, of course. Look at the face and look at the upper incisors. Different here than here. Look at the nose too, because Mauricio did the rhinoplasty. Yes, it's a patient. You need to put everything together to improve the life of the patient. Yes. Look at here, initial panel, finish panel, the screws, the long ones, and in the posterior area, and the chord in this part, we obtain a very good smile arc. Here, here, initial, finish. This is very good result too. The 3/4 change the nose. He needed that. And this is occlusal plane control. Here's the patient in Ferragamo advertisement. Yes. How many time do you have? I think it's
10 more minutes.
yes, 10 more minutes. Okay. If you want to obtain more information, you can go to this page. It's INAOMA. It's INAOMA. I am actually the president of this association, and it's international. We have people from many specialties for all around the world. It's very interesting the things that we obtain with the results. Just one case more. You know, you can change the life of the people. Look at that patient. She consulted us because she wanted a smile design. But I recommended ortho and surgery. The last thing that you need is the smile design, actually. Because you had the problems in your face. You had a low facial third, very, very short. We can improve that. Here is David Serber, Dr. David Serber. And we analyze, you know that subjective analysis is very important. Macro, mini, and microstatic. This is the first day. We start with the discord and that patient too, because we want to avoid the relapse. The relapse is produced because the masseter muscles are very hard. And if you are doing in a surgery, it doesn't work if you have a very hard masseters. And after this, we build up.
Do they have to keep getting injections after?
Yes, yes, usually. But the thing is, it's a very good question. She said if the patient needs more injections, yes. And the answer is yes. They need more. But the thing is, when we have a result for many countries, yes? We had an annual meeting for people that they work with masseters and temporalis. And the plastic surgeons, they had a big problem because they need to re-inject the patient each 4 months. Why? Because they don't pay attention to the muscles, to the bite. Just put the injection in the masseters. And if you don't fix the bite, you can obtain a good result. Because the patient, if you put the patient in a mutual protected occlusion, you are in the good way because you protect the posterior teeth. One exercise, please, before it. Oh, I don't know. One exercise. Do that, please. Take one finger, prefer your finger, okay? And put your finger between your anterior teeth, okay? With another hand, feel your masseter and bite, clench. How do you feel the masseter? And now, take off your finger for your mouth. And now, feel the masseters and clench. You feel more? Yes. That happens. When you have an interference in the posterior teeth, that happens. You can give an exercise for your masseters, and you can obtain a big masseters, more force in the masseters. But if you solve and you obtain a mutual protected occlusion, you can fix that problem, and it's better. In my patient, in my case, when I finish the cases with a mutual protected occlusion, and we just need put once per year the injections. Yes, this is very good because it's not too expensive, but it's very good for the patient. They are looking for that to feel better because they have less pain and they feel better after this. But it's just one tool. You need to put everything together. Yes. And we put 1 month before, start with the treatment. We build up everything. This is surgery first case. We put the braces today, and we go to the surgery tomorrow. It's not that the compensation process, slow process, no. It's the next day, yes? It's different, yes? And with this process, we can fix very fast everything. Dr. Liu and Frost report many years ago, after alternative surgery, the tooth movements are faster and easier. Why? Because the regional acceleratory phenomenon. What happened? All the biology is working to improve the movements. You can move the teeth faster and better. This is good for the patients because for each month you can obtain the result like 3 months. In 3 months you can obtain the result of 9 months. 3 months is the duration of this period. Yes? It's very good. This is February 6th and this is February 20. Here to here is the surgery. And go fast. It was the scheme, I don't know, the graphic for this patient, and we wanted to obtain this result. The speed, the curve of speed, and everything. When patients come back after the surgery, 2 months after the surgery, we have this patient. It's a different patient because now it's in class 1. It's not class 2, it's class 1, but we have another problem now because we had a big open bite, posterior open bite. But it's easy to fix that. Just we put biturbos in the anterior zone. Look at after 3 months, the position of the incisors really change. Go fast, very fast, and it's with very low forces. The arch is 12. It's around 12. It's very, very light forces. We use the elastics here. This is 5 months after the first day. And this is 7 months. We finished the case in 7 months. We can do that. It's not go too fast. It's just put the tools, the actual tools together, and the good team together to obtain the result. Patient change, of course, before and after 7 months, no more. And what do you think? Patient, 1 year after the treatment, she was very, very happy with us. Excuse me? No, she didn't have rhinoplasty. Just the changes in the lower face, third, because we recovered this dimension, and this was very special. Okay, I think this is everything for today. I want you understand my English and the cases. If you don't understand, I'm sorry. Thank you very much.